Good morning students. I am Dr. T. Mercy Vinolia, Assistant Professor, Department of Pediatric and Preventive Dentistry, VMSDC, Salem. Today I am going to discuss about systemic fluoridation. So, introducing what is fluoride. Fluoride is derived from the word fluore, that is the Latin word, and it is a very essential element and it is almost electronegative in nature. And how it is going to be useful for systemic as well as topical, we will see on the following slides. Fluoride in the environment. Yeah, fluoride is available in the environment. How it is available? In lithosphere, certain rocks and salts and elements, all these collects the fluorides, that is fluorospar, fluorapatite. All these rocks has a fluoride content which is present in it. And the hydrosphere is the water. In seawater it consists of about 0.8 to 1.4 milligrams per liter, and in the lakes, rivers, and it is found below 0.3 milligrams per liter. The highest content of fluoride it is seen in the lake Newburgh. And in the atmosphere, how the fluoride is available in atmosphere is from the burnt gases and the fuel from the soils as well as the gaseous and the industrial waste. The domestic burning from the coal fires, also the gases that released from the volcanic cavity. So from the biosphere, so in the biosphere the unprocessed foods. So what are all these? In the cereals, baked foods and the breads and other, all these foods has a fluoride concentration which is present in it. That's where we get the fluoride from the biosphere. And also the leafy vegetables, it consists of about 11 to 26 milligrams of the dry weight basis. Coming to the metabolism of fluoride. So metabolism, as we fluoride gets ingested, it is first is the absorption. So absorption is through stomach and the small intestines through the passive diffusion and transportation. Next is how that it is getting transported to the different parts of the body, that is by passive diffusion. It passes through the distribution through other organs, and finally it is eliminated through the kidney. So in the distributions of the body, the plasma concentration of fluoride is about 0.7 to 2.4 μm, and the saliva it is about 0.01 to 0.1 ppm, and the kidney it is about 4.16 ppm, and the enamel we have 2200 to 3200 ppm, and for the cementum it is 4500 ppm, and for the pulp it is 600 to 650 ppm. So what is the optimum level of the fluoride? So it varies with the climate, and how we find out is ppm, that is parts per million of fluoride, is equal to 0.34 divided by E, whereas E is the estimated daily water intake from the children as per the body weight, and T is the mean maximum temperature that is calculated in Fahrenheit. So the fluoride compounds and the concentrations that are used in the different systemic fluorides are, first is a water fluoridation. So the main component that is used is a hydrofluorosilicate and sodium fluoride. The concentration is about 0.7 to 1.2 milligrams per liter, whereas the salt fluoridation, the main component is a potassium fluoride and sodium fluoride, and the concentration is about 250 to 300 milligrams per kilograms. And milk fluoridation. In milk fluoridation we use sodium fluoride or disodium monofluorophosphate, and it is concentration about 5 milligrams per liter, whereas in dietary fluorides we use sodium fluoride and potassium fluoride, calcium fluoride, and concentration is about 0.25 to 1 milligrams per day. Coming to water fluoridation. So what is water fluoridation? Water fluoridation, it is defined as a controlled adjustment of the concentration of fluoride in a communal water supply to achieve the maximum caries reduction and clinically insignificant level of fluorosis. It is recommended level is, it varies between 0.8 to 1.2 ppm. So coming to the history of water fluoridation, it was first started in the 1945 in the 4 cities. So first city was Grand Rapids and Muskegon city, and the second it was Evanston and Oak Park city, and the Newburgh and Kingston city, and the Brantford and Stratford city. So we will be seeing all this in the upcoming slides. So first is the Grand Rapids and Muskegon study. In that January 25th and 1945 sodium fluoride was added to the community water supply in the Grand Rapids city, whereas Muskegon city was kept as a control, and after 6.5 years later they have found that there was a maximum caries reduction between 6 and 15-year-old kids in the Grand Rapids city than compared to the Michigan city. Whereas Newburgh and Kingston study, in this they have started it in May 2nd, 1945, where sodium fluoride was added to the communal water supply, and Kingston town was kept as a control. And after 10 years, they have found that there was a maximum caries reduction in the Newburgh city compared to the Kingston study. Then come to the Evanston and Oak Park city. In this January 1946, the fluoridation was started, water fluoridation, and the Oak Park city was kept as a control. Whereas 14 years of fluoridation they have followed up, and they have found that most of caries reduction was seen in the Evanston city compared to the Oak Park. And Brantford and Sarnia Stratford city, in this Brantford the fluoride was added to the water supply in 1945, whereas Sarnia was considered as a control group. In Sarnia there is naturally available fluoride in the water. And after few years, that is 17 years, they have found out the caries reduction was as equal to the Stanford city when compared to the Brantford city, and it was much caries reduction was seen in the Brantford city when compared to the Sarnia city. So what are the pre-requirements for the water fluoridation? So first is the presence of caries in the community and the public, and the level of fluoride concentration that is present in the drinking water. Then the generalized water supply to the community, and the community acceptance and the approval, and the installation and the maintenance cost. So the types of equipment is, first is a saturator system, then it is a dry feeder system, and then the solution feeder system. So first we will see about the saturator system. So the principle is mainly the 4% of sodium fluoride solution, it is produced and it is injected at the desired concentrations at the water distribution by the source of the pump, and the soft water enters in the bottom of the saturator tank and it flows through the bed and the bed of the sodium fluoride crystals, and then the fluoridated water is being collected. So the saturated fluoride solution, when it is flows up through the saturator, then gently it flows into the secondary storage tank and through the overflow pipe. So the metering pump, it draws the saturated solution and it injects and into the water line. The recommendations of it is mainly used in the small towns with a total requirement of the less than 3.8 million liters per day. So dry feeder system, in dry feeder system the main principle is sodium fluoride or silicofluoride, it is added in the form of a powder and involving a dissolving basin with the aid of the automatic mechanism. So recommendation is for medium sized towns, and it is about 3.8 to 1.19 million per day. So solution feeder system, coming to the solution, in this principle is the volumetric pump permitting the addition of given quantity of the hydrofluorosilic acid in proportion to the amounts of water treated. Then Venturi Fluoridator, it is a non-electrical system that was developed by J.N. Leo, activated by the flow of water in main water line, and there is no possibility of accidental overdosing by the surges of fluoride when main water pump stops. The tank is made up of a clear acrylic thermoplastic, thus enabling the operator to make the visual inspection of the level of chemical and need to replenish. Then saturated suspension cone system, in this it was developed first in Brazil, and it consists of upside down cone charged with a bag of sodium silicofluoride through which the constant flow of water percolates. The solution is collected on the top by the horizontal perforated plastic pipe which forms the outlet, and the quantity of salt in the cover cone is never been less than 25 kg. The monitoring of fluoride. So how will we monitor that how much we are adding and how much is present in the water? So Hartley check we can do of the weight of the chemical fed into the hopper, and the calorimetric check, the chemical testing, it can be done using the strain, Alzarian strain, and the continuous electromagnetic measuring controlling the fluoride in concentrations in the water. Then the effect of water fluoridation. So effect of water fluoridation, it is mainly in caries reductions, that is 50 to 60% of caries reduction is seen in the deciduous teeth, and among permanent teeth caries reduction was seen about 43% on pit and fissure caries, and 74% of proximal surface caries, and 88% of gingival surface caries. And even if the dental caries develop, the progression of lesion shows down. Then school water fluoridation. We have seen about community water fluoridation, and now it is school water fluoridation. So it was first begun in 1954 in Virgin Islands in US. The school with its own source of water is not connected to a community water supply system, that is a stand-alone system. The current recommended regimen of school water fluoridation is by adding 4.5 to 6.3 ppm of fluoride. The Venturi system is most suitable, and it is almost have no maintenance, and there has been found 25 to 40% of decrease in caries with this program. So advantages are the good results in reducing the caries and minimal equipment, and it is not expensive. Then disadvantages, if we see the child who do not receive the benefit because they have to go to the school. If they are not going to the school, they are not going to get benefited, and not all the children go to school because of low socio-economic status, and the amount of fluoride water that is drunk on the school is very less, and 5 to 6 year old to starting school they will not provide the pre-eruptive contact. Then intermittent fluoride exposure is less than 180 days in a year. Coming to salt fluoridation, it was introduced by Visby in the year of 1948 in the Switzerland, and it was marketed by 1955. The ideal level of fluoride in salt water fluoridation is 200 or 250 and 300 mg as per the fluoride per kg of salt. So the theoretical basis, Hedman et al. 2006, the ingestion of meals prepared with the fluoridated salt, he has tested, and it produced increased salivary fluoride levels, and it caused the reduction of caries. 2.2 grams of sodium fluoride has 1 ppm of fluoride. The optimum level of fluoride in the salt from Hungary in 1976 suggested after 8 years of salt fluoridation at a level of 250 milligrams, the fluoride per kg of salt reported 41% of decrease in the DMFT, that is dental caries among 2 to 6 year age group of children, and 58% of reduction of caries in children among 7 to 11 year old children, and 36% of reduction in caries among 12 to 14 year age group of children. The urinary fluoride excretion from the salt, it should be similar to that of obtained from the fluoridated drinking water, and 200 to 350 ppm of salt, 0.85 and 1.05, it is similar to the proportions of ingested fluoridated water for 10 years. The types of processing, how this salt fluoridation is being done is, one is batch processing, the another one is a continuous processing. In batch processing, the fixed amount of fluoride is added to the fixed amount of refined salt, and most commonly sodium fluoride is used, whereas in continuous processing we use a large production of production plants. There will be a conveyor belt running, in that the potassium fluoride is sprayed over the salt passing through the conveyor belt, and it is being collected. So what are the limitations of this salt fluoridation is, it may be a large variation in the salt intake among the population of different groups, and fluoridated salt consumption is the lowest when we need the fluoride in the highest in the early stages of life, and the difficulties in arises when there is a multiple drinking water fluoridation and salt fluoridation and naturally available dietary fluorides. Also it requires a refined salt produced with a modern technology with a high level technical expertise. Coming to the milk fluoridation, this was introduced by Ziegler in 1956, the community-based fluoridation. So this is was mainly found by the Boro Foundation in Bulgaria in 1988. So in this fluoride is being added to the milk. The high concentration of fluoride is needed because for the two reasons. One is the children did not drink the beverage throughout the day. Milk they will be drinking either morning or in the night, and the calcium that is present in the milk, it complexes with the fluoride, and it is reduce the availability of the fluoride for the prevention of the caries. So 2.5 to 5 milligrams of the fluoride per liter is used, that is been advised by WHO for the caries prevention, and the sodium fluoride is most commonly used for the milk fluoridation, and 1 liter of sodium fluoride is being added to the 1000 liters of milk, and the sterilization of the sodium fluoride is being achieved by autoclaving it at to 121 degree Celsius for 15 minutes and then adding to the milk and pasteurizing it. So the rationale is the milk is available through the school as well as nutritional programs, and therefore it is very cost effective and it can be targeted to the community at the greatest needs. And virtually formed milk products are suitable for the fluoridation, like milk powders, etc. And preventive effects in the milk was greater if the consumption was commenced in an earlier life. Then indications for use in non-fluoridated areas and the areas without a water fluoridation, and families with the high degrees of mobility, they are shifting, migrating from among various cities, as well as it has been noted that use of dietary fluoride supplement is not enough and it doesn't cause the caries reduction. And most commonly used is, as I said, it is sodium fluoride, and the other common products that are used are acidylated phosphofluoride and potassium fluoride and calcium fluoride. The supplements are measured, and the amount of fluorides are 0.25 mg and 0.5 mg and 1 mg, and it should be taken on the daily basis as a prescribed dosage. So the longest clinical trial for the dietary fluoride supplements, it was carried out by the Pebbles, and it was found below 3 years and 1 milligrams thereafter. It is followed in 8 to 11 years. Mean caries reduction was seen as 75% to 80%. The commercially available sodium fluoride, it is mainly 2.2 milligrams of sodium fluoride is available, that is 1 mg of fluoride, and 1.1 milligrams of sodium fluoride, that is 0.5 milligrams of fluoride, and 0.55 milligrams of sodium fluoride, which is 0.25 milligrams of fluoride. This neuromuscular coordination is very poor and it is not fully developed until 18 weeks of life, so that up to 2 years the fluoride drops are preferable than comparing the tablets. So here is age given and the fluoride concentrations of the drinking water as per American Dental Association. So the fluoride levels are seen in the water, that is whether it is less than 0.3 or it is from 0.3 to 0.6 or it is greater than 0.6 ppm. If the child is from 0 to 6 months of age, the dietary fluoride we won't prescribe, and if the child is between 3 to 6 months of age, that is if the water fluoride is less than 0.3 ppm, then we will prescribe 0.25 grams of dietary fluoride supplement. And if the water fluoride is already present 3 to 6 ppm, 0.3 to 0.6 ppm or greater than 6 ppm means no need to provide the dietary fluoridation. And if the child is between 3 to 6 years of age, then we will give 0.5 grams of dietary fluoride if the community water supply has less than 0.3 ppm of water, and if the community water supply has 0.3 to 0.6 ppm of fluoride content means we will prescribe 0.25 grams of dietary fluoride. And if it is already greater than 0.6 ppm present in the water means we will no need to prescribe the dietary fluoride supplement. And the child from 6 years to 16 years, we will prescribe 1 gram of dietary fluoride if the community water fluoride falls below 0.3 ppm. If the community water supply it has 0.3 to 0.6 ppm of fluoride, then we will prescribe about 0.5 grams of fluoride, dietary fluoride supplement. And if it is greater than 0.6 ppm in community water supplied, no need to prescribe for a dietary fluoride supplement. So coming to the fluoride toxicity, as we all know, this fluoride, it has both the positive as well as the negative effects. It's also called as a double-edged sword. So it has a good as well as a bad effect. It is divided into two types, that is acute toxicity and the chronic toxicity. So what is acute toxicity? So the acute toxicity, it results from the rapid excessive ingestion of the fluoride at one point of time. Okay, so the speed and severity of the response it depends upon the amount of fluoride that is being taken and weight and the age of the person. Okay, so the initial symptoms will be the abdominal pain, nausea, vomiting, diarrhea, increased salivation, dehydration and thirst. So this all will be the initial symptoms. Then there is something called certainly lethal dose. So what is this certainly lethal doses? The sodium fluoride for a 70 kg person, was 5 to 10 grams when it is taken orally. This corresponds to the fluoride dose of 32 to 64 milligrams of fluoride per kg. This was suggested by Hodge and Smith in 1965. So they were considered 32 to 64 mg of fluoride per kg. It is considered as a certainly lethal dose and safely tolerated dose. This safely tolerated dose is a fourth of certainly lethal dose of fluoride that can be ingested without producing any symptom of serious acute toxicity, that is 8 to 16 milligram of fluoride per kg. Then PTD, that is probably toxic dose. It is defined as a minimum dose that could cause a toxic signs and symptoms including death that triggers the immediate therapeutic intervention as well as hospitalization. The probability toxic dose of fluoride is 5 milligram fluoride per kg of body weight. So the probability toxic dose for 1 to 2 year of child is, if the child is 10 kg, then 10 into 5 milligrams of fluoride per kg, it's going to be 50 milligrams of fluoride. Then the probability toxic dose of the 5 to 6 year old of child, if the child is having 20 kg of body weight, then it is going to be 100 milligrams of fluoride. Then for an adult of 60 kg weight, it is going to be 300 milligrams of fluoride, that is 0.3 grams of fluoride. This is considered as an probably toxic dose. Then signs and symptoms of the acute fluoride toxicity. It affects the various systems in our body. One is the gastrointestinal system. It causes the abdominal pain, nausea, vomiting, diarrhea, abdominal cramps, and the neurological symptoms. This mainly affects the paresthesia, and it causes paralysis, tetany, CNS depression as well as coma, and electrolyte abnormalities, that is hypocalcemia and hypoglycemia, hypomagnesemia and hyperkalemia. And cardiovascular system, it causes a weak pulse, then hypotension, shock, and ultimately a failure. So how we are going to manage this acute fluoride toxicity is, when it is ingested 5 milligrams per kg, immediately we can give milk to induce vomiting and also induce the vomiting. Then if it is greater than 5 milligrams per kg, then first to induce the vomiting, then milk is given, a 5% of calcium gluconate can also be given, and hospitalization is necessary. Then greater than 15 milligrams per kg, in that condition first we need to induce the vomiting, and then next is the cardiac monitoring is needed and endotracheal intubation in case of life threatening situation, and administration of 10 ml of 10% of calcium gluconate to maintain the adequate urine. Then the chronic fluoride toxicity. So chronic fluoride toxicity is the symptoms when overall a period of time they are consuming the fluoride, and it causes over a longer duration due to the consumption of excess amount of fluoride. So the first is the symptom is going to be the chronic fatigue, and next the headaches and dryness of throat and excessive water consumption and frequent need to urinate, and aches and stiffness in the muscles and bones, muscular weakness, muscular spasms, and tingling sensations in the extremities, that is fingers and toes, and feeling of nauseating and pinkish and reddish spots in the extremities and the body, and skin rash. All these symptoms can indicates the chronic fluoride toxicity. Also loss of mental acuity and ability to concentrate, and depression, excessive nervousness, dizziness, tendency to lose weight, and visual disturbances, and temporarily blind spots of the field of vision, and diminished ability to focus, and possibility of retinal damage is also seen in chronic fluoride toxicity. So coming to the dental fluorosis, what is dental fluorosis is, it is an hypoplasia or hypomineralization of the tooth, enamel, and dentin produced by chronic ingestion of the excessive amount of fluoride during the period when teeth are developing. So the occurrence of dental fluorosis is almost reported most strongly associated with the cumulative fluoride intake during the development of enamel, but the severity of this condition, it depends upon the dose, duration, and timing of the fluoride intake. So in the transition and the early maturation stage of the enamel development, it appears to be more susceptible to the effects of fluoride. These stages occurs various times of different tooth types. So for the central incisors of the upper jaw, for example, most sensitive period is about 15 to 24 months for boys, and for girls it is 21 to 30 months. And concerns regarding risk of the enamel fluorosis, they are limited in the children aged less than 8 years. The enamel is no longer susceptible. Once the mature eruption is complete. Although both the primary and permanent teeth may be affected fluorosis, and uniform conditions of fluoride availability of fluorosis tend to be greater in permanent teeth than the primary teeth. Why? Because there is much of mineralization of primary teeth, it occurs before birth. So the before birth, when there is a fluoride consumption, the placental barrier, it acts as a barrier for the passage of fluoride to the fetus. So by controlling the certain amount of fluoride in the developing primary dentition. The other reasons are the period of enamel formation for the permanent teeth is almost after the birth. So once it is after the birth, the fluoride intake, dietary fluoride or water fluoride is being ingested, the primary it affects most of the primary teeth, and also the thinner enamel of primary teeth than that of permanent teeth. Then direct inhibitory effect of enzymatic action of ameloblast of fluoride, it leads to the defective matrix formation and subsequent hypomineralization in case of fluorosis. The mild changes is seen when the water fluoride increases, that is greater than 3 ppm, and severe changes is when the water fluoridation increases about 4 to 8 ppm. Then Dean has invented a fluorosis index to identify or grade the severity of fluorosis. So the hypomineralization of the teeth due to the fluorosis, this was found in 1934 by Dean, and it is later modified in 1942. So the classification is found as, first is normal, the score is 0. So the teeth, it has a translucent and semi-vitriform surface, smooth and glossy, and there is no fluorosis or hypoplastic changes. Then the questionable is 0.5 the score, and the changes what you see, the criteria what you see is the white flakes that can be seen in the occasional spots that is present in the enamel. Then very mild, it scores 1, that is small opaque paper white areas of 1 to 2 mm, it is seen in the cusp tips as well as incisal edges of the molars and incisors. Then mild, it scores of 2, it is almost more extensive, but it do not involve as much as 50% of tooth surface. Then the moderate, it scores for 3, where the enamel is affected and it is getting untreated, and it shows the wear and also the brown stains are also seen. Then severe, it scores for 4, whereas brown stains, then mottled enamel, also the pitting on the surfaces of the enamels are also seen. It looks like a corroded appearance. So by this grading we will know the severity of the fluorosis that is present in the individual. Then the skeletal fluorosis. What is skeletal fluorosis? When a fluoride is readily incorporated in the crystalline structure of a bone, it will get accumulated in the various areas, resulting in the condition called skeletal fluorosis. So it causes the increased bone density, but it reduces its flexibility, and it causes the joint pain as well as the stiffness. So it has various categories, stage 1, 2 and 3. The third stage, it goes for crippling and it affects the mobility of the bone. And stage 2, the mobility is not significantly affected, but it is characterized as sporadic pain, stiffness of the joints, osteosclerosis, that is bone thickening on the pelvis and spine. Then coming to the symptoms and side effects. So the bone is hardened and it is becoming less elastic. So there will be a fractures of the bones, and the thickening of the bone and accumulations of the bone tissue, it causes the impaired joint mobility, and also it ruptures the stomach lining and it causes nausea, then damages the thyroid gland leading to hyperparathyroidism, and then uncontrolled secretions of parathyroid hormones, the depletion of calcium in the bone structures, and as a higher calcium concentrations in the blood, as a result of bone flexibility decreases and making them more amenable for the fractures. So coming to defluoridation of water. So in case of a fluoride toxicity, that is acute toxicity as well as a chronic toxicity, and in case of dental fluorosis and skeletal fluorosis, what we need to do is a defluoridation of the water. When the water level of fluoride is excess, this definitely going to cause the toxicity. So that particular condition, we need to know the defluoridation techniques. So what are all the defluoridation techniques are? One is the adsorption technique, and another one is the ion exchange technique, and the third one is going to be the precipitation technique. So in the adsorption technique, what we are going to do is we are putting the bone charcoal, processed bone, tricalcium phosphate, alum, alumina, so serpentine, tamarind gel, all these substance that is going to absorb the fluoride that is present excess in the water. Then the ion exchange technique, in this the cations and anions exchange resins are used, and then precipitation techniques, in this Nalanda technique is being followed. So we will see each of them. So first is the adsorption technique. In adsorption technique, most commonly used are activated alumina and activated carbon. So the process with the pH specific, the pH of the solution is kept between 5 to 6 as the level. If the pH is greater than 7, then silicate and hydroxide become stronger competitor for the fluoride ions, and the exchange sites is on activated alumina. McKay and Johnston in 1934 investigated the use of powdered activated carbon of fluoride for the fluoride removal, and achieved the good results. Adsorption shows the enchanted removal of fluoride by 82.1% at the equilibrium constant time of 15 minutes. So this explains the adsorption technique. And next is going to be the ion exchange technique. In ion exchange technique, we use cations as well as the anion. In cations, we use the group like carboxylic group and sulfuric acid. They are capable of giving the H plus ions, whereas in anionic groups we carry the tertiary and quaternary amine groups, which is sodium hydroxide that gives the hydroxyl ions. Then polyanion, it removes the fluoride at the rate of 862 milligrams per kg and 1040 milligrams per kg. This study was carried out by Mohan Rao and Bhaskaran in Andhra Pradesh, and he experienced the several materials that found the ion exchange resins. It removed the fluoride of about 5 milligrams per liter and 1.5 milligrams per liter. So there are two major drawbacks in the ion exchange techniques and absorption techniques. The necessary flow through the system is often difficult, and to arrange there is no piped water supply, and the gradual exhaustion of active agent is not being easily detected. Coming to the Nalanda technique, this was developed by NEERI, that is National Environmental Engineering Research Institute, and it was found in Nagpur, and they evolved as an economically and simple method for the removal of the fluoride, which is referred to as a Nalanda technique. So the three components are mainly used in this technique. One is alum, then lime and bleaching powder. So the unit of 22 liters of water which is filled into the upper chamber. The lime alum, it is mixed to the water supply, and it is over a period of 30 to 60 seconds and the speed of about 10 to 20 rpm, and it is uniformly dispersed, and then the formation of microflocks as result in the proper utilization of the chemical coagulant. And then the second stage, the formation of suitable particle flocks. It forms the destabilized colloidal particles, and then gently prolong the mixing of period from 10 to 15 minutes and with the speed of 2 to 4 rpm. Then it's going to sediment. The sedimentation, it is the separation from the water by a gravitational setting of suspended particles than heavier from the water. So that is called sedimentation. Then once the fluoride is all sedimented, then is going to be the filtration. The filtration is a process of separating the suspended colloidal impurities from the water that passes through the porous media, and the flocculated water, this allowed to settle and filter through the fullers of earth candle overnight, and then treated water will be available for the drinking. So this is the Nalanda technique that is being followed. And advantages are the regeneration of media is not required, and no handling of the caustic acids and alkalines as we do it in the chemical method, and chemicals required are readily available to use as a conventional water treatment, and then adaptable to domestic use, and then it can be used to treat the waters in a large quantity for the community usage, and highly efficient for the removal of the fluoride that is present at the higher level in the water. And the wastage of water, it has a least disposal system, very little water wastage, and the least disposal system is noted. Then modifications of this Nalanda technique is they have used a polyaluminum chloride, and also they have tried with the polyhydroxy sulfate that requires a less flocculation time and setting time, and it is showed the experiment appropriate range of pH. The defluoridation by coagulation is 5.5 to 6.5 as per Sujana et al. In 1998. Coming to the membrane technique, so what is membrane technique is mainly based on the principle of reverse osmosis. So in reverse osmosis, what happens is the method contaminants are removed by applying the direct pressure through the semi-permeable membrane, and the large size fluoride molecules, it will stay back, and the smaller size, because the pores are very smaller in size in the filter which is present, and the fluoride ions is removed by 98% by the reverse osmosis. So this picture we can see the reverse osmosis, the small porous membrane that will allow only the water, and the large particles of fluoride is going to be stay back by applying the maximum pressure, and this is called as a reverse osmosis technique. The electrodialysis is a membrane technique, but it is used in the direct current instead of pressure in reverse osmosis to separate the ionic contaminants. This technique is also shows the good removal of the fluoride. And this safe water network installed many RO plants, that is reverse osmosis plants, in India in states of Telangana and Uttar Pradesh. So this is a 2 bucket system that we can see in Tanzania. So the fluoridated water which is present, in that the lime and alum is being added, and it is being mixed and for 30 seconds, and then a screen of cloth is kept, and the water is being collected in another bucket, which is a defluoridated water that passes through the sieved cloth, and the fluorides are all whichever present in the fluoridated water that stays back in the sieved cloth, and the defluoridated water is collected in the another bucket. So to conclude, when use the appropriate fluoride in a safe and effective agent, that can be used to prevent the dental caries, and the fluoride is needed throughout the life to protect the healthy teeth and against the dental caries. But still systemic fluorides are not yet widespread in India, but therefore to ensure the additional gains of oral health practices in water fluoridation should be extended to the additional communities, and also through the fluoride toothpaste that should be used very widely. These are the references that I have referred. Thank you.